So, we discuss question number 287 from GT 183. So, question number 287 of GT 183 was: parents bring their newborn daughter to you for consultation about diagnosis and management. Their first two children, a boy and a girl, have a complete form of albinism with pink iridis, blonde hair and pale skin. Which of the following represents your correct advice concerning the newborn child? So you have four options and we will discuss this question now. So you see here that the parents here are normal. You see, they have not mentioned here, but it is apparent that the parents here are normal and they have two children, a boy and a girl, that are affected. So there are two things that you have to note here. First, the parents are normal, and the second, two children are affected, one boy and one girl, and this is a case of ocular cutaneous albinism, which follows autosomal recessive pattern of inheritance. So here we are discussing about ocular cutaneous albinism, which has a autosomal recessive pattern of inheritance. It has a autosomal recessive pattern of inheritance. So what does that mean? That means that parents may be normal. Suppose this is the normal allele and this is the affected allele. So similarly, this is again in the second parent, if this is the normal allele and this is the affected allele, so what would be the offspring like? So the offspring, it is possible, could be any of these. So you see here, if there is an autosomal recessive pattern and if the parents are normal because they have one normal allele, so in that case you have 1/4 risk of having a affected child. So is that clear? So this is the risk. So in all these three cases, it will be an unaffected child or unaffected. In this case, if the allele, if the formation is this, it will be unaffected, and if this is what the alleles will be like, then it will be an affected child. So there is 1/4 risk of. So there is a 1/4 risk of having an affected child. So what are the options that you were having in this question? You had option number A, a 1/8 risk of albinism and skin cancer from DNA deletions. And option number B was again 1/8 risk for albinism and skin cancer from DNA cross-linkage. C was 1/4 risk for albinism and skin cancer and from DNA deletions, and option number D was again 1/4 risk for albinism and skin cancer. So like we have discussed here, the risk is 1/4. So we know here, so the options number A and B are out. So the option number, we have to choose our answer from option number C and D, where the risk is 1/4. So the other thing that the option are different in the causation of skin cancer. So option number C says skin cancer resulting from DNA deletions, and option number D says skin cancer resulting from DNA cross-linkages. So the correct option to this question is option number D, where there is a 1/4 risk for albinism and skin cancer from DNA cross-linkages, because it has been seen that damage due to albinism because of absence of melanin causes more DNA damage due to DNA cross-linkages rather than DNA mutations and DNA deletions. So DNA cross-linkages are seen to be the more common form of DNA damage in case of patients of oculocutaneous albinism. So the correct option in this question is option number D. So now we come on to question number 288. Question number 288 was, identify the disorder given in the X-ray below. And the options that you have were laryngomalacia, recurrent laryngeal papillomatosis, epiglottitis and CRU. So you see the X-ray here clearly. What do you see in this X-ray? This is the trachea. If you see, this is the trachea. But if you see clearly, there is some narrowing that is seen here. Okay? If you see clearly, this narrowing is what is depicted in this X-ray. And this narrowing is known as the Steeple sign. I will first tell you the correct answer to this question and then we will discuss about it. So basically in this X-ray, you see this narrowing in the subglottic part of the trachea, which is called the Steeple sign, and it is seen in the condition called CRU, or it is also known as laryngotracheobronchitis. So the correct answer to question number 288 is option number D, which is CRU, and it is also known as laryngotracheobronchitis. Where we have seen that there is narrowing of the subglottic area of the trachea. The subglottic part of trachea results in the Steeple sign. And the sign that we are seeing in this X-ray is this area, which is the narrowing. If you can see, you can compare it with this area. This is the apparently normal caliber of the trachea if you see on the X-ray, and this is the narrowing, which resembles the steeple of the church, and that is why it is called the Steeple sign. Characteristically seen in the condition called CRU or laryngotracheobronchitis, or it is in short also known as LTB. So this is the Steeple sign, which is seen in frontal X-rays or frontal neck radiographs. CRU often results in children from the age group of 1 to 5 years, and it presents as characteristically as biphasic stridor. Stridor is a very common presentation, and in this condition there may be biphasic stridor, there may be barking cough, and there may be low-grade fever as well, along with fever. Okay, so this is very important. Stridor is very important presentation of CRU or laryngotracheobronchitis. What is the commonest causative organism? Well, it is a viral illness, and the most commonly implicated organism is parainfluenzae virus type 1. Usually in this condition we will admit the child depending upon the severity. So in some patients there might be just barking cough, stridor may not be present, and in some cases stridor may be present when the child is crying or is irritable, and in severe cases stridor may be present even at rest. So if you are encountering a child who has stridor at rest, he is always to be admitted. So in case you find a child who has stridor at rest, then it is an indication for admission. Okay. So these are the important points that you should remember when about CRU, because you might get an MCQ about these parameters as well. So if there is stridor at rest, this is an indication for admission. And how do you treat such a child who has CRU? Well, in most of the cases, if it is mild, then reassurance, cool mist, and hydration is what is required. However, in severe cases, if suppose the child is unable to take orally, or if he has stridor at rest, then, and if you are admitting, then the important components of management of CRU include epinephrine or adrenaline, which is given by nebulization, and also we can give dexamethasone, in a dose of 0.3 to 0.6 mg per kg single dose. Preferably you can give it IM as well, because sometimes looking for the IV site can itself cause a lot of anxiety and irritability in the child and can increase the respiratory distress. So you can give dexamethasone even by an intramuscular route. So these are few important points of with regard to CRU that I would like to discuss again. First, the sign that we saw here in this X-ray was the steeple sign, which resembles the steeple of the church, and that is how it is given this name. It results because of the narrowing of the subglottic part of the trachea. It is usually seen in the frontal neck radiographs. CRU is a condition which is normally seen in children between 1 to 5 years of age. It is characterized by biphasic stridor, barking cough, and children may have low-grade fever. The most common virus that is implicated in the causation of CRU is parainfluenzae virus type 1. And if a child has stridor at rest, this becomes an indication for admission. However, children who have mild illness, who have only barking cough, or who do not have stridor at rest may be sent home by giving them reassurance, advising them on cool mist, and advising them on hydration. Patients who are admitted in the hospital may require epinephrine, which is administered through nebulization, or they may also be given dexamethasone in a dose of 0.3 to 0.6 mg per kg, which may be given in an IM dose, which reduces the duration of the illness. So that are the few important points that you need to know about CRU or laryngotracheobronchitis. So now we come on to the next question, which is question number 289. And question number 289 was, a child died soon after birth. On examination, there was hepatosplenomegaly and edema all over the body. Most probable diagnosis is. So you see in this condition, they are talking about a child who has died soon after birth, and on examination there was hepatosplenomegaly and there was edema all over the body. So the condition that they are describing here is of hydrops fetalis. So the condition here is hydrops fetalis, where you find there is skin edema, the child dies soon after birth, there is hepatosplenomegaly. So they are describing about hydrops fetalis. And we should know that this is a serious fetal condition which is defined by abnormal accumulation of fluid, in 2 or more compartments. Two or more fetal compartments. This may include pleural effusion, it may include pericardial effusion, it can include ascites, or it can also include skin edema. These children will also have anemia and hepatosplenomegaly. In 1970s, in earlier years, the most common cause of hydrops fetalis that was known was Rh immunization. This was an older common cause of hydrops fetalis. But now, with the advent of anti-D administration in high-risk mothers, the cause of immune causes of hydrops fetalis have reduced significantly. So now Rh immunization is no longer the common cause of hydrops fetalis. Now non-immune causes of hydrops fetalis are more common. They are more common. And what are these non-immune causes of hydrops that are common? They are, amongst the common causes include alpha-thalassemia, and another important cause is parvovirus B19 infection if it happens in pregnancy. So what is alpha-thalassemia? So now if you see the choices, so you have alpha-thalassemia as the choice number B in this question. So the correct answer to this question was option number B, alpha-thalassemia. So we will talk in brief about alpha-thalassemia. So now in alpha-thalassemia, each individual inherits 2 genes from each parent. So the genotype is written as alpha-alpha and alpha-alpha. Now alpha-thalassemia can result either because of deletion of one of the genes or a mutation that affects one of the pairs. But if both these pairs are affected, then it results in the most severe form of alpha-thalassemia, where hydrops fetalis will result and the child may die even in utero. So the most severe form of alpha-thalassemia, where all the 4 genes are affected, results in hydrops fetalis and early fetal death. So the correct answer to this question was alpha-thalassemia. Now if you see the choices here in this question, if you weren't aware of alpha-thalassemia, then you can also make out a diagnosis by exclusion here. So beta-thalassemia usually presents around 7 to 9 months of age, when the adult hemoglobin starts to take over. So that is the most common time for presentation of beta-thalassemia. And in hereditary spherocytosis, again, the presentation is usually later. Sickle cell anemia, again, the most common form of presentation in case of sickle cell anemia is bone pains because of sickle cell crisis. So this question could have also been answered if in case you were not aware of alpha-thalassemia as a cause of hydrops fetalis. So now we come on to our next question, which is an image-based question, and question number 290. So you were supposed to identify the syndrome from this image, and the options that you had were Prader-Willi syndrome, Turner syndrome, Down syndrome, and Marfan syndrome. So question number 290, the correct answer is Marfan syndrome. So the correct option is option number D, Marfan syndrome. So what do we see here? If you see this picture, slightly a taller child there is some scoliosis, if you can appreciate well, and you see there are long facies, long arms. So these are suggestive of Marfan syndrome. So what is Marfan syndrome? Well, it is a genetic disorder which is caused by mutations in the fibrillin-1 gene. It is a genetic disorder that results due to mutations in fibrillin 1 gene, which is ubiquitously present or expressed in the connective tissues. It has a autosomal dominant pattern of inheritance. Autosomal dominant pattern of inheritance. And it can have various skeletal malformations which include thoracolumbar scoliosis, thoracic lordosis, and pectus excavatum. Which can all lead to restrictive form of lung disease because of these skeletal deformities. And apart from that, there can be eye abnormalities as well, which can lead to blindness, and the eye problems include glaucoma, retinal detachment, and cataracts. So we see that Marfan syndrome is a genetic disorder. It results due to mutations in fibrillin 1 gene, which is expressed in the extracellular matrix. It has an autosomal dominant pattern of inheritance. The important skeletal malformations in Marfan syndrome include thoracolumbar scoliosis, thoracic lordosis. There can be pectus excavatum as well. And all these conditions, these skeletal malformations can cause restrictive form of lung disease. There can be eye problems as well, which include pectus excavatum, retinal detachment, and cataracts. And apart from that, they are known to cause deaths because of aortic dissection or aortic root dilatation. Because most of these conditions, if you see, it is basically a defect in the extracellular matrix or the collagen. So wherever these form an important area, it will result in problems. So this is the important cause of death in patients of Marfan syndrome. Okay, so with this we come on to our next question, which is question number 291. And question number 291 was, which of the following therapies has been found to be effective in long-term follow-up for some patients with the X-linked neurodegenerative disease, Adrenoleukodystrophy? So the choices that you have are vegetable oil as a dietary supplement, hyperbaric oxygen therapy, bone marrow transplantation, and total volume exchange blood transfusion. So the correct answer to this question is option number C, which is bone marrow transplantation. So they are talking about X-linked neurodegenerative disease, adrenoleukodystrophy. So we will discuss something about X-linked adrenoleukodystrophy. So we should know that this is one of the most common paroxysmal disorder. It is X-linked. First, it is X-linked, as the name suggests. It is a X-linked disorder. It is the most common paroxysmal disorder. It results basically because of a defect in the gene that is present on the X gene, which is responsible for the transmembrane protein, which is responsible for the transport of very long chain fatty acids from the cytosol to the peroxisomes. So basically this transmembrane protein is defective in adrenoleukodystrophy. So what happens is the VLCFAs start accumulating. So there is an abnormal accumulation of very long chain fatty acids in case of adrenoleukodystrophy in various organs, most importantly being white matter of the brain, spinal cord, and the adrenal cortex. One of the most common presentations of adrenoleukodystrophy is adrenal insufficiency, and which can manifest even years before neurological symptoms start to appear. Adrenal insufficiency is one of the most common presenting features of adrenoleukodystrophy, sometimes even years before neurological symptoms have appeared. So these are few important points about adrenoleukodystrophy, and bone marrow transplantation is seen to be the treatment in some patients. So bone marrow transplantation is one of the treatment options available for some patients, and apart from that, a new therapy or an experimental therapy that is also being tried includes administration of Lorenzo oil. Now this Lorenzo oil has been seen to block the synthesis of VLCFAs, which are accumulating in the body because of the defective transmembrane proteins. So it is an experimental therapy which is being considered. So these are the few important points about X-linked adrenoleukodystrophy. Like the question itself had mentioned, they were talking about a neurodegenerative disease. So you know that it is a X-linked disorder. It is a neurodegenerative disease. It is a X-linked disorder. It is the most common paroxysmal disorder. It results due to the defect in the transmembrane protein, which is responsible for the transport of the very long chain fatty acids from the cytosol to the peroxisomes, which result in abnormal accumulation of VLCFAs in various organs, including the white matter of the brain, the spinal cord, and the adrenal cortex. Adrenal insufficiency is one of the most common presenting features of adrenoleukodystrophy. Sometimes it can be seen years before neurological symptoms have presented. Bone marrow transplantation is one of the important therapeutic options that are available for this type of neurodegenerative disease. And another experimental therapy that is being considered for future use may be the use of Lorenzo oil. So with this, we come on to our next question, question number 292. So question number 292 was, a normal anion gap acidosis is most likely to be due to, and the options that you had were diabetes mellitus, renal tubular acidosis, nephrotic syndrome, and uremia. So a normal anion gap acidosis, the correct option to this question is option number B, and that is renal tubular acidosis or RTA. that is the correct option to this question. So now we will just in brief talk about anion gap. So now what is anion gap? Now anion gap is the difference between measured cations and measured anions. It is the difference between measured cations and measured anions. So what does that mean? That means the most common measured cations are usually potassium and sodium and potassium, but because potassium has a very low concentration, for practical purposes this equation becomes like this. So the anion gap is, the measured anions include bicarbonate and chloride. The normal concentration of anion gap is taken to be 8 to 12 milliequivalents per liter. And acidosis can result either, and acidosis can be either a high anion gap acidosis or a normal anion gap acidosis. So what are the conditions where you can have a high anion gap or an increased anion gap? Well, you can remember this with the help of a mnemonic which is commonly used for this, and that is the mud piles. So these conditions usually result in high anion gap acidosis, and these include M stands for methylene glycol acidosis or addition of methylene glycol. U stands for uremia. T stands for diabetic ketoacidosis. P stands for propylene glycol toxicity. Propylene glycol toxicity. I stands for isopropylene toxicity. The next is important, and that is lactic acidosis. E again is important, results due to ethanol poisoning. And S stands for salicylate poisoning. So these are the causes of high anion gap acidosis: methylene glycol, uremia, diabetic ketoacidosis, propylene glycol poisoning, isopropylene alcohol poisoning, lactic acidosis, ethanol poisoning, and salicylate poisoning. And what are the causes of normal anion gap acidosis? Well, there are two important causes of normal anion gap acidosis, and that includes that is renal tubular acidosis and diarrhea. So these are the important conditions which will cause normal anion gap acidosis. So that is what our question was. A normal anion gap acidosis most likely results due to renal tubular acidosis. So now we come on to question number 293. And question number 293 was, question number 293 was, common posterior fossa tumors in children include all except, and the options that you had were medulloblastoma, ependymoma, cerebellar astrocytoma and oligodendroglioma. So the correct answer to this question is question number D, which is oligodendroglioma. So some important points about brain tumors in children specifically. So CNS tumors, they account for almost 20% of all neoplasms in children less than 15 years of age. And they are the second most common neoplasms, second to leukemias. They are the second most common form of pediatric cancers. And the most common CNS tumors in India, they have been found to be astrocytic tumors, followed by medulloblastomas and supratentorial primitive ectodermal tumors, and oligodendrogliomas are very rare. So the most common include the astrocytomas, then the medulloblastomas, and then ependymomas, and oligodendrogliomas are very rare. So with this we now come on to question number 294. And question number 294 was, a 5-year-old child with systemic onset GIA is found to have leukopenia, thrombocytopenia and raised ferritin levels in serum. What should be suspected? And the options that you have are development of acute lymphoblastic leukemia, development of MAS, clinical relapse of systemic onset GIA, or etanercept toxicity. And the correct answer to this question is option number B, that is development of macrophage activation syndrome. So the answer to this question is option number B, and that is activation of macrophage activation syndrome. Now, MAS is one of the most important or a life-threatening complication of systemic onset GIA. Now, GIA can be of 3 types: pauciarticular, where less than 4 joints are affected, or polyarticular, less than or equal to 4, or polyarticular, where more than 4 joints are affected, or systemic onset GIA, in which systemic symptoms will predominant, usually fever and rash. So this is how GIA is classified: pauci, poly and systemic onset GIA. So macrophage activation syndrome is one of the most important life-threatening complications that can result in patients with systemic onset GIA, and it is characterized by few important features which include pancytopenia, the patient starts developing high fever, there may be lymphadenopathy, and hepatosplenomegaly. There may be liver insufficiency. There may be thrombocytopenia. Fibrinogen levels may fall. And serum ferritin levels may be increased markedly. This condition can be confirmed on the basis of bone marrow biopsy, which will suggest hemophagocytosis. A bone marrow biopsy will show hemophagocytosis, and its treatment will require methylprednisolone or cyclosporin. Okay, so we see that macrophage activation syndrome may result in pancytopenia. Patient may have high fever. There may be lymphadenopathy, hepatosplenomegaly, there may be liver insufficiency, there may be thrombocytopenia. Fibrinogen levels may be reduced, ferritin levels may be increased, diagnosis may be confirmed by bone marrow biopsy, which will reveal hemophagocytosis, and treatment involves administration of methylprednisolone or cyclosporin. So we come to our next question, which is question number 295. And question number 295, what is the normal time of disappearance of this neonatal reflex? So you see here, and the options that you have are birth, 2 to 3 months, 5 to 6 months, and D, persists throughout life. So the correct option to this question, that is question number 295, is C, 5 to 6 months. And what were we seeing in this image? We saw, this is the image of a asymmetric tonic neck reflex, or ATNR as it is commonly called. So this is ATNR or asymmetric tonic neck reflex. So you see here, as the baby's head is towards the left side, the left arm is also extended. If you see, can you see? The left arm is also extended. So this is what is seen in ATNR. So when the child is in supine position and is not crying, he may be seen to lie with his head turned to one side with the arm extended to the same side. And it is not visible here, but if you can appreciate, the other arm is flexed, and similar is the case with the contralateral knee as well. So the contralateral knee will also be flexed. So this is the ATNR. Normally it is seen that this reflex is seen to be present. It is seen at 35, it develops at 35 weeks of intrauterine life, and it has been seen to persist up till 5 to 6 months of age. However, in children with CP, it is seen to disappear by 5 to 6 months of age. But it can persist for lifelong, may persist lifelong in children with spastic cerebral palsy. So these are the few points that you need to know about ATNR or asymmetric tonic neck reflex. So now we come on to our next question, which is question number 296. And question number 296 was, a 4-year-old child is brought in by her mother because of a painful honey-colored crusted lesion on her face. The most likely diagnosis is malaria, impetigo, cellulitis, and seborrheic dermatitis. So the correct answer to this question is the option number B, which is impetigo. So impetigo is a contagious disease that is most commonly due to either streptococcal infection or a staphylococcal infection. And usually it involves the epidermis. Usually what happens is there are certain lesions, fluid-filled lesions, which are usually on the face, and they are filled with honey-like discharge, and whenever they get burst, the discharge comes out, and wherever the discharge goes, the new lesions will start appearing. So this is seen in impetigo. What happens in cellulitis is it is usually the infection or again caused by both streptococcal or staphylococcal, but in cellulitis the infection is usually slightly deeper, and in cellulitis it basically involves the dermal or the subcutaneous planes. And there are no exudates. Often the area may become red, inflamed, and the area may be indurated in case of cellulitis. So the signs of inflammation may also be present, and area may become indurated. And in case of seborrheic dermatitis, there are scaly or erythematous lesions that may also get crusted, but it is generally localized to the scalp and the intertrigonous areas. So this was about impetigo. We now come on to our next question, which is question number 297. And question number 297 is, common site of regional enteritis in children is dedinojejunum, B. Ileum cecum, C. Colon rectum, and D. Rectum. So the correct answer to this question is option number B, that is ileum and cecum. So now we should first know what is regional enteritis. Actually, regional enteritis is another name for Crohn's disease. And in Crohn's disease, we all know that it involves the entire GI tract. But the most common area to be involved in case of Crohn's disease is ileocecal area. And another important feature of Crohn's disease is that the lesions are discontinuous. And that is why it is called, sometimes also called regional enteritis. So because the lesions are discontinuous, or there may be another word that can be used is, they can be skip lesions. So skip lesions, there's a lesion, then there's a normal area of the GI tract, then there is an affected area, so there are skip lesions. On an endoscopy, you may find irregular, serpiginous, or aphthous ulcers. with intervening normal mucosa. And this was the endoscopic finding. On histopathology, there may be transmural inflammation with non-caseating granulomas. So we see that regional enteritis is also known as Crohn's disease. It involves the entire GI tract. Ileocecal region is the most common area where it is affected. The lesions may be discontinuous or they may be skip lesions. On endoscopy, we may find irregular or serpiginous or aphthous ulcers, and on histopathology, we may see transmural inflammation with non-caseating granuloma. So with this, we come on to our next question, that is question number 298. And question number 298 is, statement incorrect about development is: pincer grasp at 3 months, sitting at 6 months, social smile at 3 months, and 2-year-old can use plurals. So the correct answer to question number 298 is option A, pincer grasp at 3 months. So we know that how does the grasp develops. So you have bidextrous grasp at 5 months. You have palmar grasp at around 7 months. And you have pincer grasp at 9 months. So you were asked about the false or the incorrect statement about development, which was pincer grasp at 9 months. So the correction here would be pincer grasp is seen at 9 months. So now we come on to question number 299, and question number 299, you again get an image and you are asked which of the following is depicted in the picture below. So the options that you had were tube feeding, assisted feeding, supplementary suckling technique, and the third option was improper feeding technique. So here if you see the image clearly, you see that the mother is holding the baby in the lap. Along with that, she has a cup, and in that cup you can see there is a tube here, and there is a leucoplast or some adhesive here, and the baby is suckling at the breast. So this technique, which is approved by the WHO as well, is the supplementary suckling technique. So the option number C is the correct answer to this question. So question number 299 was an image-based question, and the correct answer to that question was option number C, which is the supplementary suckling technique. So this is the correct option, and as we see, it is, I will explain it again, it is used in mothers who have either mothers with maternal insufficiency, mothers in milk insufficiency, or it is also can be practiced in mothers with lactation failure. So what happens in this technique is, the cup is held down and the tube is there inside, one end of the tube is inside the cup is filled with milk, and the baby is allowed to suckle at the breast, and with the tube he will be able to bring some milk from the cup, he will be nourished, he will be satisfied, but at the same time by the suckling technique the mother may be able to produce milk, which has, if there's lactation failure has occurred. So that is how reinitiation of lactation is tried in mothers who have either failed or there is milk insufficiency through supplementary suckling technique. So now we come on to question number 300. Question number 300 was, a child in 3rd grade has problems with spelling and reading. She appears very quiet and confused in the class. Her mind seems to wander whenever the teacher tells a story or explains something complicated. She is skilled in art and so far has performed well in arithmetic. Which of the following diagnostic procedures is most likely to yield useful findings in this child? So the options that you have are intelligence test, language evaluation, psychiatric assessment to rule out depression, and 4th, neurological examination. So the correct answer to this question is option number B, which is language evaluation. Okay. So now how we have reached to this conclusion? So we see the child is in 3rd grade, and he has problems with spelling and reading. So what is the important point here is, if you see, it mentions that she is skilled in art and so far has performed well in arithmetic. So this child does not need a intelligence test, because if he is performing well in arithmetic, that means her IQ is probably normal. What she is not able to understand is when there is a story or when the teacher is explaining something complicated. So when she has to when she has to join too many things together in an abstract manner, then she has a problem. So then a language evaluation in this child will be of use. So that is how we have reached to this answer, that is language evaluation. So the correct answer to question number 300 is language evaluation.